Welcome back to the deep dive. Our mission is always the same. You provide the source material, the core knowledge, and we provide the shortcut, the interpretation, and the high-impact anchors you need to quickly become fluent in the topic.
Exactly.
Today, we are undertaking a critical deep dive into trauma essentials, specifically focusing on Chapter 30 from the 28th edition of Baily and Love's textbook of surgery, the neck and spine.
And this is a dense, high-stakes chapter. So we want to assure you, the dedicated learner, that this is not just a dry regurgitation of the text.
No, absolutely not.
Think of this deep dive as a powerful revision tool. It's a ready reckoner, really, designed to distill the essential, critical concepts.
We're interpreting the anatomy, right? The gold standard assessment tools.
The nuances of management, and of course those crucial complications that come with spinal trauma. Our focus today is squarely on understanding spinal stability and the clinical pathways that, maximize neurological outcomes.
We can't stress this enough. Use this deep dive alongside the full text. It's a companion, not a replacement.
Absolutely, for maximum benefit.
Okay, let's unpack this and jump right into the blueprint. To understand injury, we first have to master the foundational architecture of the vertebral column. We'll start with the absolute basic functional unit of the spine, which the chapter calls the motion segment.
Right.
What exactly is this fundamental building block, and why is it our starting point?
Well, the motion segment is, it's everything. It's the basic functional component, and it defines both movement and stability.
So it's more than just the bone.
Oh, much more. It consists of two adjacent vertebrae, the crucial intervertebral disc that sits between them.
The shock absorber.
The shock absorber and the spacer, exactly. And critically, all the powerful surrounding ligamentous and soft tissue restraints that hold the whole thing together.
So when we talk about a traumatic spinal injury,
we're almost always talking about the failure of one or more components of that motion segment. The bone, the disc, the ligaments, something has given way.
and as we move up and down the spine, the design of these segments changes dramatically. The upper cervical spine, so C1, the atlas, and C2, the axis, is built completely differently from the rest, isn't it?
It is entirely unique. I mean, think about what it has to do. The C1-C2 complex is engineered almost exclusively for maximum motion.
For turning your head, nodding.
Exactly. We need that rotational and nodding capacity to interact with the world. The atlas C1 sits on the skull, and the axis C2 gives it that central pivot point, the dens, or the odontoid peg. It's all about mobility, not bony interlocking.
So if it doesn't have that inherent bony stability, where does its structural integrity come from? How does it not just fall apart?
It relies almost entirely on incredibly powerful ligamentous restraints. The key structure here is the cruciate ligament, and specifically its strongest component, the transverse band.
And what does that do?
It's like a seatbelt. It holds the dens of C2 tightly against the back of the C1 arch. So if those powerful ligaments fail, which usually happens in very high-energy trauma,
You have catastrophic instability.
catastrophic instability at the craniocervical junction, it often leads to immediate fatality or, a devastating neurological injury. And it's simply because the bony elements are designed for motion, not for load-bearing stability.
So that's our first big anatomy anchor.
That's your first one. Upper cervical stability equals ligamentous integrity. It's all about the ligaments.
Okay, so moving past that very specialized C1, C2 region, we hit the more standard C3 to C7 segments, but then we encounter what the chapter calls the danger zones, the transitional zones.
Yes. And you have to know these. These are the 2 points where the structural rigidity of the spine just abruptly changes.
And that makes them weak points.
They're structural weak points, highly prone to injury because they absorb all the changing forces. The first one is the cervicothoracic junction, so C7 to T1.
Where the mobile neck meets the fixed chest.
Precisely. You have the extremely mobile neck meeting the relatively fixed thoracic spine, which is, of course, braced by the entire rib cage.
And the second one.
The second, and you could argue it's the most critical, is the thoracolumbar junction. That's T11 to L2.
Right.
Here, the fixed kyphotic or forward-curving thoracic spine abruptly transitions to the mobile lordotic or backward-curving lumbar spine. All the forces of acceleration, deceleration, and rotation just get concentrated in those 2 zones.
And that structural vulnerability leads us directly into the core concept of instability. This brings us to the essential framework for initial trauma assessment, the 3-column model.
Dennis's model, yeah.
But before we define what makes something unstable, we need to be really clear on what stability even means in this context.
It's a good point. Spinal stability is defined as the ability to withstand normal physiological loads without progressive deformity, severe pain, or any neurological compromise.
And the Dennis three-column model is the conceptual framework we use to figure out when that ability has been lost.
Exactly. It's the framework we use to identify the failure points.
So let's quickly run through those three columns for everyone listening. We have the anterior column.
Right. Which is the anterior two-thirds of the vertebral body, and that big, tough anterior longitudinal ligament that runs down the front.
Then there's the middle column.
And this is the crucial one. The middle column is the posterior wall of the vertebral body and the posterior longitudinal ligament.
Why is it so critical?
Because it's the back wall of the vertebral body. Any failure here, or any bone fragment that gets pushed back, what we call retropulsion, immediately threatens the spinal cord, which is sitting right behind it.
And finally, the posterior column.
That's everything else at the back. It's all the posterior bony elements, the pedicles, laminae, spinous processes, and the whole posterior ligamentous complex. So the interspinous and supraspinous ligaments, and of course the facet joints.
Which gives us the crucial rule of instability.
Yes. And it's derived directly from this model, and it's a simple rule to remember. If two or more of these columns are injured, the spine is considered mechanically unstable.
So just one column failing might be okay, but two is a definite problem.
If two or more fail, that structural instability means the spine can't bear load safely. Intervention is required to prevent immediate or future neurological deterioration or, progressive deformity.
Now, this model is the foundation, but the chapter also stresses the importance of the more modern, detailed systems, specifically the AO classification, particularly for the thoracolumbar spine.
Right.
Why do we need the AO system when Dennis's model already gives us that simple two-column instability rule?
That's a great question. Dennis tells us if it's unstable. The AO system, which was developed by groups like Maygerl and has been refined since, tells us the mechanism of failure.
And that dictates the treatment.
It dictates surgical planning far more accurately. The AO classification is critical because it moves beyond just counting failed columns, and it categorizes injuries based on the dominant force: compression, distraction, or rotation and translation.
Okay, let's anchor these AO types clearly for the learner. Let's start with type A.
AO type A is for compression injuries. These are failures due to axial compression. So think of a simple wedge fracture where the anterior column fails.
Like from a fall.
Exactly. Or a burst fracture where the vertebral body is crushed in multiple directions, pushing fragments back into the canal. That's a failure of the anterior and the middle columns. So a type A injury can be stable if only one column fails, but a big burst is often unstable.
Okay, what about type B?
AO type B is for distraction injuries. These are tension band injuries. The spine is literally pulled apart. This typically leads to failure of the posterior elements, the posterior column under tension.
One of the classic examples
Is the chance fracture, which we'll come back to. It involves the bony and ligamentous posterior complex being pulled apart. Type B injuries almost always involve failure of at least two columns and are inherently unstable.
And finally, the most severe, type C.
AO type C is for translational or rotational injuries. These are the worst. They involve displacement of one segment relative to another through Alekhine translation or rotation around the axis.
This sounds like it would have to break everything.
It does. These mechanisms necessarily disrupt all three columns. They are considered grossly unstable, and they often carry the highest neurological risk.
So to put it all together, the Dennis model is the quick diagnostic rule two columns fail, it's unstable.
Right.
And the AO classification is the language surgeons use to actually plan the fixation. A, B, or C tells you the mechanism and what kind of stability constructs you'll need to build. That's a really powerful distinction.
Exactly. It's the evolution from a descriptive model to a predictive and a prescriptive one.
Perfect. Now we have to turn to the neurological component, the highway system that runs through this bony structure. The spinal cord anatomy itself provides several crucial landmarks that really influence prognosis.
Yeah, and the primary landmark, the first thing you have to know is where the spinal cord proper actually ends.
It doesn't run all the way down, does it?
No. In adults, the cord extends from the foramen magnum down to about the L1, L2 level. That endpoint is called the conus medullaris.
And below that?
Below L1, L2, you're dealing with the bundle of nerve roots known as the cauda equina, which means horse's tail.
And that distinction is fundamental for recovery.
It's everything. Injuries to the spinal cord, which is central nervous system tissue, typically have very poor recovery potential. But injuries to the cauda equina, which are peripheral nervous system roots, generally have a much better prognosis for regeneration and recovery.
Okay, so inside that cord, we have the three major highways, or tracks. each with a different traffic rule about decussation or crossing over. How should the learner mentally map these?
I like to think of it in terms of local versus long-distance travel. First, you have the lateral spinothalamic tracts. These carry pain and temperature sensations. They take the immediate neighborhood route,
Meaning they cross over right away?
very locally. They cross over to the opposite side of the spinal cord, typically within about 3 levels of where they enter. So a lesion on the right side of the cord will cause loss of pain and temperature on the opposite or left side, starting almost immediately at that level.
Got it. What's next?
Next are the lateral corticospinal tracts. These carry our voluntary motor function. They take the long-distance route.
So they don't cross locally.
No, they originate way up in the motor cortex, and they cross over high up at the pyramidal decussation in the brainstem, at the craniocervical junction. So, a lesion in the spinal cord below that crossing point will cause motor loss on the same side, the ipsilateral side.
Okay, and the third highway?
The posterior columns. These carry proprioception, so position, sense vibration, and deep pressure. They also take the long-distance route. They ascend ipsilaterally on the same side until they also cross high up in the lower brainstem.
So a spinal cord lesion causes loss of these senses on the same side as the injury as well.
Correct. So to summarize for the listener, motor function and position, sense corticospinal and posterior columns are lost on the same side as the lesion. Pain and temperature spinothalamic are lost on the opposite side, and that's a critical distinction for diagnosing incomplete syndromes later on.
Right, like Brown-Séquard.
Exactly. And one last anatomical point. Remember the topographical arrangement. Within these highways, the nerves serving the proximal body, so the trunk, are arranged centrally, while those serving the distal body, the hands and feet, are arranged peripherally. This is key to understanding the pattern of recovery in syndromes like central cord syndrome.
That provides a really robust anatomical foundation.
Yeah.
Before we move on to assessment, let's just quickly check back in with you, the learner. Check-in question. Can you quickly name the 2 anatomical junctions most prone to injury and define the 3 types of injury mechanism categorized by the AO classification? If you need a moment, just pause the audio now.
Okay, the answers are the cervicothoracic junction and the thoracolumbar junction. And the AO types are A for compression, B for distraction or tension, and C for rotation or translation.
And if you struggled with those AO types, please make a note to just rewind and revisit that specific classification. It's that important.
It is.
So our key takeaway 1 is this. Upper cervical spine stability is ligamentous. Instability is defined by failure of 2 or more Dennis columns. L1, L2 marks the end of the cord proper, and the AO system classifies injuries by mechanism A, B, and C.
Perfect summary.
Now let's move directly to the clinical setting. The moment a trauma patient arrives, the mindset has to be one of immediate suspicion. ATLS principles are mandatory in all spinal trauma cases.
Absolutely.
And the mantra is, every trauma patient has a spinal injury until proven otherwise. This means immediate full spinal precautions and immobilization.
This is completely non-negotiable, but that initial triage carries a massive and often missed clinical trap.
Which is?
The risk of a secondary injury at a remote level.
Yeah.
The sources are very clear on this. If you identify one spinal fracture, you have to be hypervigilant because approximately 10% of cases have a second spinal injury somewhere else.
A non-contiguous fracture.
Exactly. And missing that second injury can lead to severe neurological deterioration later on. It's a huge pitfall.
And the procedure for immobilization itself, it comes with a pretty important caveat regarding the equipment we use, doesn't it?
It does. Spinal boards should strictly be used for transfer only. They are essential for moving the patient safely from the scene to the emergency department.
But they're not for long-term use.
Not at all. They cause rapid tissue ischemia and pressure sores, especially in patients who are insensate or have to be immobilized for extended periods. The patient must be transferred off that board and onto a proper trauma mattress as quickly as the primary and secondary surveys will allow.
Let's address the diagnostic dilemma of the unconscious patient,
Yeah.
because that's so common in polytrauma.
Yes.
So, let's try a fictional case study. The unconscious patient. The patient is admitted after a high-speed car crash. They're unconscious, GCS of 7, and they're intubated. Standard CT head and body scans are performed, and they show no obvious cervical spine fracture, but the visualization of the C7-T1 junction is a bit suboptimal. The patient obviously can't participate in the neurological exam. What is the standard of care here regarding spinal clearance and immobilization?
This is a classic scenario because the patient cannot participate in the clinical assessment. They can't report pain, they can't check motor power, they can't confirm sensation, you cannot clear the spine clinically, it's impossible.
So what do you do?
You are forced to maintain full spinal immobilization. Usually that means a rigid collar. And that collar stays on until advanced imaging, typically a dedicated thin-cut CT or ideally an MRI, definitively rules out an unstable injury.
Especially a ligamentous one.
Especially in the ligamentous structures that CT can struggle with. If the patient remains unconscious, that collar stays on until an MRI is safe and conclusive. We simply cannot afford to miss a ligamentous C1-C2 injury or a difficult-to-see C7-T1 dislocation.
So once the immediate life threats, the primary survey, are addressed, the physical examination has to be meticulous. You noted a crucial clinical pearl about how a spinal cord injury can complicate the abdominal assessment.
Yes, this is so important. The systems examination, the secondary survey, must proceed head to toe. And the pearl is this. A high spinal cord injury can cause a widespread neurological deficit that completely masks the signs of an intra-abdominal injury.
So they might not feel the pain from a bleeding spleen.
Exactly. A patient with a T6 injury or higher might not perceive pain from a ruptured spleen or a perforated bowel. It completely obscures the standard signs of internal bleeding. So vigilance, repeat examinations, and a really low threshold for imaging are mandatory here.
And the spine itself requires full visualization via a spinal log roll.
Correct. The entire team has to roll the patient onto their side as a single unit, maintaining perfect spinal alignment to inspect and palpate the whole vertebral column from the occiput to the sacrum.
What are you looking for?
You're looking for obvious swelling, tenderness, or a palpable bony gap or step-off, which strongly suggests a major ligamentous disruption and a vertebral dislocation.
You also mentioned looking for markers of high-energy trauma, specifically seatbelt marks.
Yes. A seatbelt, mark the ecchymosis or bruising across the chest or abdomen, is a massive warning sign. It indicates an extremely high energy transfer, often from a sudden violent flexion during deceleration.
And it's associated with specific injuries.
Highly associated with chance fractures in the thoracolumbar region, and crucially, it demands an urgent search for associated internal injuries, particularly those involving the abdominal viscera, the pancreas, the duodenum, and major vessels like the aorta. The seatbelt essentially crushes the organs against the spine, and that violent flexion causes the spinal distraction injury.
This systematic approach leads us to the standard language of neurological assessment, the American Spinal Injury Association, AZA system. This is the functional map for every learner.
It is. The ASIA system uses the Medical Research Council, or MRC, grading system for motor function, which goes from 0 to 5. It maps 10 key muscles on each side of the body, giving a total possible motor score of 100.
And for clinical planning, we define functional motor power as what grade?
MRC grade 3 out of 5 or higher. That means the muscle can move actively against gravity. Below a 3 out of 5, the function is generally considered non-useful for independent living.
And what about the sensory assessment?
Sensation is mapped at 28 dermatomes on each side of the body. We assess both light touch and pinprick sensation. The neurological level of the injury is then defined as the most caudal, or lowest level, with both normal sensory and normal motor function.
But the most vital assessment for determining the prognosis is the S4-5 assessment. Why is this one small area so incredibly critical?
The S4-5 dermatome, which is perianal sensation, and the motor function voluntary anal contraction and anal tone are the definitive discriminators between a complete and an incomplete injury.
So it all comes down to that.
It all comes down to that. If any sensory or motor function is preserved in S4-5, the injury is by definition incomplete. This means some tracts are still intact through the lesion site, and that significantly shifts the prognosis toward greater functional recovery. If S4-5 function is completely absent, the injury is defined as complete, or AIS A.
Let's map out the Asia Impairment Scale, the AIS, which turns these findings into a functional ladder for grading the severity.
Okay, so AIS A is complete. No sensory or motor function is preserved in the S4-5 segments. The injury is complete.
Right.
AISB is sensory incomplete. Sensory function is present in S4-5, or it's present below the neurological level, but there is no motor function below the neurological level.
Then we get to C and D, which are both motor incomplete.
Right. AISC is motor incomplete, but non-useful. Motor function is preserved below the neurological level, but less than half of the key muscle groups below that level have useful motor power, meaning they're grade 2 or less.
And D is the opposite.
AISD is motor incomplete and useful. Motor function is preserved, and half or more of the key muscle groups below the neurological level have useful motor power, so that's grade 3 or higher.
And AISE is normal.
AISE is normal motor and sensory function.
So just to be clear, if a patient can only wiggle their toes, so MRC 1 out of 5, but they have S4-5 sensation, that would be an AIC. But if they can lift their feet against gravity MRC 3 out of 5, and they have that S4-5 sensation, that jumps them up to an AISD. The S4-5 check is the gatekeeper.
It is the absolute gatekeeper.
Okay, let's test this understanding.
Let's do it.
Checking question. A 45-year-old male presents with a T8 burst fracture. On examination, he has intact light touch sensation down to T10, but below T10, there is no motor function whatsoever. Crucially, the rectal exam reveals no perianal sensation and no voluntary anal contraction. What is his ASIA impairment scale grade and why? I'll give you a moment to pause and recall.
Okay, the answer here is AISA. It's a complete injury.
Even with that patchy sensation down to T10.
Yes. That patchy sensation is irrelevant in determining completeness. Completeness AISA is rigorously defined by the absolute absence of sensory or motor function in the S4-5 segments. If S4-5 is gone, it is a complete injury, regardless of whether some residual function exists at higher levels below the T8 injury itself.
That's a critical point. So key takeaway 2. Always suspect a second spinal injury. That's the 10% remote injury risk. Remember that SCI can mask intra-abdominal injury signs, and functional completeness relies solely on the S4-5 assessment via the ASHA scale. You've got it. The next stage is visualization. Once we suspect an injury, imaging is what confirms the extent of the damage. We usually start with plain radiographs, specifically the cervical series AP, lateral, and the open mouth views.
And the mandatory technical requirement here is clear visualization of the cervicothoracic junction, C7 to T1.
Yep. Back to the danger zone.
Always. We mentioned it's a high-risk transitional zone, and it is the single most common area for a missed injury on plain films purely because of shoulder overlap. If you cannot see it clearly, you have to pull the shoulders down.
The swimmer's view.
The swimmer's view in difficult cases, or you just proceed immediately to CT. You cannot clear the neck if you can't see C7-T1.
And if a fracture is found on those initial films, we escalate the imaging survey.
The 15% rule is your diagnostic anchor here. If you find any spinal fracture, you must image the entire spine because 15% of patients will have a second, non-contiguous fracture somewhere else. It is a failure of care to assume the injury is localized to just one level.
Okay, focusing on the systematic evaluation of the lateral cervical spine film, which is really the primary imaging tool in the initial triage, the textbook requires a rigorous checklist for assessing stability.
Yes, and this is critical for that initial look. First, you always assess the prevertebral soft tissue swelling. Significant swelling in front of the vertebrae suggests a major hemorrhage and, very likely, a significant ligamentous disruption.
Step 2.
Step 2, assess the sagittal alignment using the 3 imaginary lines: the anterior vertebral line, the posterior vertebral line, and the spinal laminar line. Any break or step in that gentle, smooth lordotic curve means you have trouble.
And the third step is about specific measurements that confirm acute instability.
Yes, instability is structurally confirmed if you find either of 2 things. 1, greater than 3.5 millimeters of horizontal sagittal translation of one vertebra on another.
So it's slipped forward.
Slip forward more than 3.5 millimeters. Or 2, sagittal angulation of greater than 11 degrees compared to the adjacent level. If you meet either of those criteria, the spine is defined as mechanically unstable, and that necessitates immediate definitive management, regardless of the patient's current neurological status.
Now, when we move beyond plain film, which imaging modality is the absolute workhorse for bony trauma?
It's computed tomography, CT. It is the gold standard for defining bone architecture, for identifying comminution, for quantifying canal compromise from those retropulsed bone fragments, and crucially, for assessing the fracture type according to the AO classification.
And in the polytrauma patient?
In the polytrauma patient, a CT of the head, chest, abdomen, and pelvis often covers the entire spine anyway, which is ideal.
But the CT is effectively blind to the most critical soft tissues, the neurolomas themselves and the ligaments. That's where MRI comes in.
Exactly. Magnetic resonance imaging, or MRI, is the gold standard for soft tissue assessment. And the key indication is this: all patients with a neurological deficit require an MRI.
No exceptions.
No exceptions. It allows you to visualize the spinal cord itself. You can see contusion, edema, hemorrhage, and it is the only way to reliably assess the crucial ligamentous structures, especially the posterior ligamentous complex, which dictates stability in those distraction type B or rotational type C, injuries where the bone might look relatively intact, but the soft tissue has completely failed.
A final warning regarding imaging: the use of dynamic studies.
Yes. Lateral flexion extension radiographs, where you ask the patient to actively move their neck, should never be performed in the acute setting if instability is suspected or proven, or if the patient is uncooperative.
Why not?
The risk of exacerbating the injury and causing neurological damage is just far too high. They are reserved only for a delayed chronic assessment of uncertain stability, usually weeks later.
Okay, so that's a clear roadmap. Key takeaway 3. CT is for detailed bone assessment. MRI is mandatory for any neurological deficit or suspected ligamentous failure. The CT junction must be visualized, and dynamic imaging is dangerous in the acute setting.
That covers it.
We've diagnosed the damage. Now we move to intervention. The initial goals are straightforward: realignment and stabilization. If we have a subluxation or dislocation in the cervical spine, how do we achieve that critical realignment without immediately going to surgery?
The initial treatment for a cervical subluxation or dislocation is often skeletal traction using skull tongs, like Gardner-Wells tongs.
How does that work?
It involves applying progressive, controlled weight to the skull to gently pull the displaced vertebrae back into alignment. This maneuver has to be done extremely carefully, often with fluoroscopic or radiographic guidance, because too much force can worsen the neurological deficit.
But if it's successful?
If it's successful, that realignment immediately achieves what we call indirect decompression of the spinal cord. Alternatively, a halo brace can be used, which can facilitate both a closed reduction and also provide really robust external immobilization for certain stable injuries.
Okay, so when does this non-operative management transition to open surgical intervention? We know the criteria are the injury pattern, pain, instability, and of course the neurological deficit. But what is the one single non-negotiable factor that forces your hand?
This is the anchor point for all learners when it comes to spinal trauma management. The only absolute indication for emergent surgical intervention is deteriorating neurological function.
Not just a deficit, but a worsening deficit.
A worsening deficit. If a patient is stable, but then begins to lose motor power or sensation over time, that demands immediate decompression and stabilization in the operating room. All other surgical indications are relative. The timing might be debated, but deterioration is a true emergency.
And when we take the patient to the OR, the surgical goals are twofold: decompression and stabilization. Talk to us about the rationale for direct versus indirect decompression.
Right, so indirect decompression is what we achieve simply by reducing the fracture or dislocation. Realignment restores the normal diameter of the vertebral canal, and that relieves compression on the cord caused by the deformity itself.
But sometimes that's not enough.
Sometimes it's not. If imaging, specifically the MRI, shows persistent neural compression, say from a large bone fragment that's been retropulsed from a burst fracture, or a significant epidural hematoma, then a direct decompression is required.
Which means surgically removing it.
It means surgically removing the offending tissue, often via a laminectomy or a specific anterior approach, to physically free the neural elements.
Now, we mentioned the AO classification before. How does that translate into the surgical approach? For instance, in the thoracolumbar spine, many surgeons now opt for a posterior approach for stabilization, even for fractures that look like primary anterior and middle column failures, like a type A burst fracture. Why is posterior favored?
This is where surgical biomechanics really becomes important. When we stabilize the thoracolumbar spine from the back posteriorly with rods and screws, we are effectively creating a powerful posterior tension band.
What does that mean?
Well, the goal isn't just to hold it still, it's to correct any kyphosis, that forward bending deformity, and to prevent flexion forces from further collapsing the already damaged vertebral body. A posterior fixation construct, especially if you use distraction across the fracture site, can even indirectly decompress the canal through something called ligamentotaxis.
Ligamentotaxis.
You're essentially pulling on the intact posterior longitudinal ligament, which in turn can pull those retropulsed bone fragments back out of the canal. Anterior approaches, which mean going through the chest or abdomen to get to the front of the spine.
They sound much more invasive.
They are far more invasive. They carry much higher morbidity risk of lung injury, visceral injury, and are now reserved only for cases where a direct, definitive anterior column reconstruction, say with a cage, is absolutely necessary. For most burst fractures, posterior fixation is preferred because it has a lower risk profile and it's so effective as a tension band.
Let's pivot to pharmacotherapy. We have to address the historical controversy regarding corticosteroids. This is a defining medical fact that the learner must master.
This is a massive change in practice, a huge one. For acute traumatic spinal cord injury, or SCI, corticosteroids, specifically high-dose methylprednisolone, which was used for years based on the Naskis trials, are no longer indicated.
Why the change?
They are not recommended because the risk of significant complications, we're talking infection, wound breakdown, gastrointestinal bleeding, outweighs the very limited and frankly non-reproducible benefit that was seen in those early trials.
But the textbook reminds us they still have a critical function in spinal pathology, just not the traumatic kind.
Correct. And this distinction is crucial. Steroids are still used in non-traumatic spinal cord compression, like compression caused by metastases or malignant tumors.
What do they do there?
They reduce the surrounding inflammation and edema, and that provides temporary neurological improvement and pain relief. So the anchor stands. In acute traumatic SCI, steroids are OUT. In non-traumatic compression, like from a malignancy, they are IN.
Let's solidify this management hierarchy with a complex case study that really focuses on that absolute indication for surgery.
Good idea.
Fictional case study, management dilemma. A 30-year-old construction worker falls 5 stories. He has a T12 burst fracture, an AO type A3, and he's initially graded as AISD, useful motor function below the lesion. He's hemodynamically stable, and he's scheduled for stabilization surgery tomorrow morning.
Okay, a standard plan so far.
But 3 hours before the planned operation, the nursing staff reports he can no longer feel pinprick sensation below T10, and his bilateral foot dorsiflexion power has dropped from an MRC 3 out of 5 to a 1 out of 5.
Okay, that is a critical scenario that tests your clinical judgment. The absolute non-negotiable next step is to cancel the elective timing and proceed immediately to the operating room for emergent decompression and stabilization.
Why the immediate shift? We were planning surgery for the morning anyway. What's a few hours?
A few hours is everything. It's because the patient is now exhibiting deteriorating neurological status. That drop from AISD to potentially an AIC or even A means the secondary injury, the swelling, the hemorrhage, the movement of bone fragments is actively progressing.
So you have to intervene now to stop it.
Any delay in decompressing the neural elements in the situation could lead to a permanent loss of function that wasn't there an hour ago. While the surgery itself is for stabilization, the acute goal has now shifted to stopping the deterioration, and that means immediate intervention.
So stability planning takes a backseat to emergent decompression in this rare but catastrophic circumstance.
Precisely. Life-saving always trumps elective, and function preservation always trumps timing.
Okay, that's crystal clear. Key takeaway 4. The absolute surgical indication is neurological deterioration. Skeletal traction can achieve indirect decompression for cervical subluxations. Posterior fixation is often preferred for thoracolumbar stabilization due to its tension band effect. And steroids are out for acute traumatic SCI, but they are in for non-traumatic compression.
Excellent.
We'll now drill down into specific high-yield injury patterns, starting again at that highly unstable upper cervical spine, the skull to C2.
Right at the top, the most dangerous injury here is occipito-atlantal dislocation, or OAD. This is a severe failure of that ligamentous complex holding the skull into C1.
A very high-energy injury.
Very high energy, often fatal at the scene. If the patient survives, we assess the Powers ratio radiographically to define the skull translation, and definitive treatment is usually surgical, an occipito-cervical fusion or robust external immobilization with a halo brace.
Okay, next, the classic C1 fracture, the Jefferson fracture.
This is a ring fracture of C1. It's caused by axial loading, so driving the skull down onto the relatively fixed C1 ring. The critical stability anchor here is all about the transverse ligament.
How do you assess that?
We assess its integrity by measuring the combined lateral mass deviation on the open mouth X-ray view. If that deviation exceeds 6.9 millimeters, it strongly suggests a rupture of the transverse ligament, and that makes the fracture unstable.
And if the ligament is intact?
If the ligament is intact, the injury can often be managed non-operatively in a collar or a halo.
Moving down to C2, we have the most common C2 injury, the odontoid peg fracture.
We classify these into 3 types. The type 2 fracture, which occurs right at the base of the dens, is the most problematic.
Why is that?
It has a poor blood supply and a high incidence of displacement and non-union, meaning it doesn't heal. Since neurological injury is actually rare with these, our focus is just on stabilization.
So what's the treatment?
For displaced type 2 fractures, internal fixation with an anterior compression screw is often the preference, aiming for direct bony healing. If non-union occurs, a posterior C12 fusion is required.
And there's a unique point for the elderly.
Yes, for the learner, remember this. In the frail elderly, a soft collar may occasionally be chosen. You're aiming to promote a stable pseudarthrosis or fibrous union, prioritizing comfort over aggressive surgery.
What about the hangman's fracture?
This is a traumatic spondylolisthesis of C2 on C3. It's a fracture through the pedicles of C2. While the name suggests hyperextension, we now understand that many result from simultaneous flexion and distraction. Management depends heavily on stability and displacement. Highly displaced types, or those with associated facet dislocations, typically require posterior operative stabilization.
Okay, shifting down to the subaxial cervical spine, C3, C7, injuries here, like facet dislocations or burst fractures, are statistically more commonly associated with spinal cord injury than those in the upper cervical spine.
That's a really key distinction. The subaxial spine provides better bony stability, but it has a smaller vertebral canal relative to the cord. That makes the cord highly vulnerable when a bony element fails. These injuries almost always require operative stabilization and decompression.
We have to pause here again for a critical caveat concerning patients with ankylosing spondylitis, or AS.
Yes, this is a clinical hazard that absolutely must be remembered. AS, or a similar condition called dechoche, transforms the spine into a rigid, brittle rod, the bamboo spine.
And they fracture easily.
They fracture from very low energy trauma, and the fracture plane often goes straight through these rigid fused segments. The risk of neurological injury is exponentially higher.
So what's the takeaway for the clinician?
When you encounter an AS patient after trauma, senior surgical advice is mandatory. Do not force the neck into a standard cervical collar if it causes discomfort. You manage the patient in a position of comfort until imaging is complete. These rigid fractures almost universally require robust surgical stabilization, often including multiple levels above and below the fracture itself.
Okay, moving down into the thoracic spine, T1, T10, the commonest injury in the older population is the osteoporotic wedge compression fracture.
These are your classic type A injuries. They're typically stable and they heal well. However, if they cause significant symptomatic pain or a progressive kyphotic deformity, we can intervene with bone cement augmentation.
And the learner needs to know the difference between the two techniques.
Right. Vertebroplasty involves simply injecting cement polymethyl methacrylate into the collapsed vertebral body to relieve pain and stabilize it. Kyphoplasty uses a balloon to first expand the collapsed space before you inject the cement, and that often restores some of the lost vertebral height and helps correct the kyphotic deformity.
Now, the unstable, high-energy thoracic fractures carry unique danger signs that demand vigilance in the polytrauma setting, pointing toward a catastrophic vascular injury.
This is a must-know association. An unstable thoracic spine disruption, say a type C rotational injury, combined with a sternal fracture carries a massive established risk of aortic rupture or transection.
Why that specific combination?
The force required to simultaneously break the sternum at the front and the fixed thoracic spine at the back is immense. If you see this combination, a CT angiogram is mandatory to rule out great vessel injury.
Finally, we reach the thoracolumbar junction, T11, L2, the second major transitional zone. Here, we're going to focus on burst and chance fractures.
Right. The burst fracture is the classic type of injury involving vertebral body comminution, widening of the pedicles, and, most importantly, retropulsion of bone fragments into the spinal canal. As we discussed, management is generally posterior fixation, leveraging that tension band effect.
And the chance fracture provides the clearest anchor we have, tying a specific spinal mechanism to a visceral injury.
It does. The chance fracture is the classic lap belt injury. It's an AO type B, a distraction injury, where the torso is thrown forward over a fixed lap belt, violently tearing apart the posterior and often the middle columns.
And the associated clinical pearl is non-negotiable.
Absolutely not. Chance fractures are associated with major visceral and vascular injuries, including ruptures of the duodenum, the pancreas, and/or the aorta. If you see this fracture, you must perform a thorough abdominal assessment and get imaging, usually a CT of the abdomen, because that internal organ injury may be far more life-threatening than the spine injury itself.
We get it. slight prognosis bump as we move down into the lower lumbar spine, L3S1.
We do. L3 to S1 injuries generally have a better prognosis for non-surgical treatment and for recovery potential.
And why is that?
Because the spinal cord has already terminated at L1, L2. We're dealing with the more resilient nerve roots of the cauda equina, and the canal is also more capacious down there, meaning retropulse fragments are less likely to cause a dense, permanent neurological deficit.
Okay, that's a fantastic tour of the regions. Key takeaway 5. The AO classification dictates surgical planning. Eighth patients require extreme surgical caution. A thoracic fracture plus a sternal fracture means you have to look for an aortic rupture. Chance fractures are lap belt injuries requiring an urgent visceral investigation. And the prognosis is better below L2 in the cauda equina.
A great summary.
We shift now from the structure to the microscopic fight against damage. The source divides the pathophysiology of spinal cord injury, or SCI, into two distinct phases. Why is this distinction so crucial for our therapeutic strategy?
It's crucial because we can only treat one of the phases. The primary injury is the direct, unpreventable mechanical insult at the moment of trauma. The shear, the compression, the contusion. That's done.
So all of our modern management is aimed at the second phase.
All of it. The goal is minimizing the secondary injury.
And what causes this secondary phase?
It's the biochemical cascade of damage that unfolds in the minutes and hours right after the impact. This includes progressive hemorrhage, edema, inflammation, and ischemia. This ongoing process is what expands the initial deficit.
And it can be made worse.
Critically, this secondary damage is significantly aggravated by 3 systemic issues: hypotension, hypoxia, and ongoing instability. So all our therapeutic efforts are focused on maintaining mean arterial pressure, ensuring adequate oxygenation, and stabilizing the spine to provide the best possible environment for the neural tissue to survive.
Maintaining circulation is paramount. But here we hit the 3 critical types of shock that have to be instantly differentiated, as mistreating one as the other can be fatal. Let's establish a clear comparative framework for the learner.
Yes. We have to compare the signs of standard blood loss, shock hypovolemic, with the specific circulatory shock of a high spinal cord injury, which is neurogenic.
Okay, let's start with hypovolemic shock, or standard blood loss.
Right. The blood pressure is low hypotension. The heart rate is fast tachycardia as the body tries to compensate.
And the peripheries.
The peripheries are cold and clammy due to massive systemic vasoconstriction. The treatment is aggressive volume resuscitation with blood products and fluids.
Now, compare that to neurogenic shock, which you see in a high SCI above T5.
Okay. The blood pressure is also low hypotension, but the heart rate is slow bradycardia, or normal.
Why is it slow?
It's due to the loss of sympathetic outflow, which leaves the parasympathetic vagal tone completely unopposed. And the peripheries are warm and dry because the loss of that sympathetic tone prevents vasoconstriction. It's a distributive shock.
And the treatment is completely different.
Completely. The primary focus is restoring vascular tone and chronotropy with inotropic support, like dopamine or norepinephrine. You have to be cautious with fluids to avoid pulmonary edema because the system is dilated, not depleted.
So the differentiation is purely based on the heart rate and the peripheral status. Tachycardia plus cold peripheries means blood loss. Bradycardia plus warm peripheries means neurogenic failure.
That's the key, precisely. And the third type of shock is often confused with neurogenic, but it's completely physiological.
Spinal shock.
Yes. This is not a circulatory problem. It is a temporary state of physiological disorganization of spinal cord function that happens immediately after the injury. It's characterized by flaccid paralysis, loss of muscle tone, and hyporeflexia below the level of the injury.
How long does it last?
It can last for days or even weeks, and a patient can be in neurogenic shock, the circulatory problem, and spinal shock, the physiological problem, at the same time.
And the critical anchor for the learner is how you know when it's over.
Yes. Its resolution is confirmed by the return of the bulbocavernosus reflex, which is a reflex involving S3S4. Once that reflex comes back, the patient's permanent neurological status can be determined, and the flaccidity usually transitions into spasticity.
Now, regarding prognosis, we return to the concept of completeness and the specific incomplete syndromes.
Right. Remember, an injury is incomplete if there is any preservation of that S4-5 function. The incomplete syndromes are complex, and they're defined by which tracks are affected. You have central cord syndrome, often from a hyperextension injury, which causes greater motor impairment in the upper limbs than the lower limbs.
And Brown-Séquard.
Brown-Séquard syndrome, which is a cord hemisection, that gives you ipsilateral motor loss and position sense loss, with contralateral pain and temperature loss. And then anterior cord syndrome, which is loss of motor and pain and temperature below the lesion, but it preserves the posterior column function. The key is that all incomplete injuries have a significantly better prognosis for useful recovery than a complete AIS injury.
And that long-term prognosis is heavily tied to the neurological level, which dictates independence. Let's just expand on the functional goals based on the level, because this is the ultimate measure of the outcome.
It is. Functional outcomes are entirely level dependent. At the top, C1 to C4 injuries often leave the patient ventilator dependent or requiring assisted coughing. They have total dependence for activities of daily living, or ADLs.
How do they get around?
Mobility requires sip and puff or chin-controlled electric wheelchairs, and life expectancy is, unfortunately, severely limited.
What about a C5 injury?
C5, you get elbow flexors, the biceps. This is a big deal. It allows for some feeding with adaptive equipment and controlled movement of the arm, leading to improved independence in a power chair.
Then C6.
C6 is a crucial functional jump. The patient can actively extend their wrist, which allows for a tenodesis grasp using passive finger flexion when the wrist is extended. They can often perform ADLs with assistance, manage their bladder, and potentially use a manual wheelchair on level surfaces.
And C7 is even better.
C7 is a highly functional level. You get elbow extensors, the triceps. This enables independent transfers, independent use of a manual wheelchair, and significant ADL independence.
And then below that, you have paraplegia.
T1 to T12 injuries mean paraplegia. They have full upper limb function. Independence in ADLs and transfers is possible. Mobility is via a manual wheelchair, and lower thoracic injuries like T11, T12 may even allow for short-distance walking with extensive bracing.
Finally, we have to cover the highly prevalent long-term complications, which often determine the quality of life for the SCI patient.
Yes. Pressure ulcers are the classic, highly preventable complication managed through meticulous turning protocols and specialized pressure-relieving mattresses. Pain and spasticity are nearly universal. Severe resistant spasticity often requires specialized treatment, like a pump for continuous intrathecal baclofen infusion into the spinal fluid.
And what about the most life-threatening chronic complication?
Autonomic dysreflexia. This is a neurological emergency, and it's predominantly seen in injuries at or above T6. It's a paroxysmal, exaggerated sympathetic response to a noxious stimulus below the level of the injury. It manifests as a sudden, massive surge in blood pressure, severe hypertension that could lead to a stroke, accompanied by flushing, sweating, and a pounding headache above the injury level, and a slow heart rate, bradycardia.
What are the anchors for the immediate treatment? What do you do?
The immediate life-saving management is to identify and remove the trigger. The two common anchors you must remember are bladder distension from a kinked catheter or a full bladder, or fecal impaction from severe constipation. If the hypertension persists, you give pharmacological treatment like short-acting nitrates while you address the cause. Missing this diagnosis can be catastrophic.
In other long-term issues?
You have post-traumatic syringomyelia, which are fluid-filled cysts in the cord that can cause progressive pain and weakness years later, generalized osteoporosis from lack of load bearing, and a significant risk of thromboembolic events, DVT, in 30%, and a fatal PE in 1 to 2% of patients.
Which means prophylaxis is key.
That high DVT-PE risk mandates routine, time-critical thromboprophylaxis, usually low molecular weight heparin and compression stockings, in the acute phase, as long as there's no active bleeding.
Let's end this section with one final check-in.
Okay.
Check-in question. You're reviewing the chart of a patient with a C5 tetraplegia. They suddenly spike a blood pressure of 210 over 105. They're sweating profusely in the face and neck, but their legs are pale. What is the most likely diagnosis, and what should be the immediate first-line investigation? I'll give you a moment to pause.
The diagnosis is autonomic dysreflexia. It's indicated by the severe hypertension and that specific pattern of flushing above the injury and paleness below. The immediate investigation must be to check the urinary catheter for kinks or blockage for bladder distension, and then to assess for fecal impaction.
This has been an incredibly detailed interpretation of the essentials of spinal trauma. We've established the anchors needed for rapid recall, from the ligamentous stability of C1 and C2 to the biomechanics of the three-column model and the mechanism-based AO classification.
And we clarified those crucial clinical differentiation points. The non-negotiable S4-5 assessment for completeness, the 3 lines of the lateral film, the absolute indication for emergent surgery being neurological deterioration, and most critically, that immediate distinction required between hypovolemic, neurogenic, and spinal shock based on heart rate and peripheral temperature. We really hope this ready reckoner empowers your study.
And as we've noted, the goal of acute management is minimizing the secondary injury, that hemorrhage, edema, and biochemical fallout that expands the damage zone. But given that spinal cord tissue cannot regenerate effectively and the prognosis for neurological recovery remains so limited, how might future therapeutic strategies, beyond simply stabilizing the spine, evolve to target the primary injury itself?
That's the million-dollar question.
Are we on the cusp of surgical or biological interventions that could actually repair the cord at the moment of impact and fundamentally change our expectations for functional outcome in complete SCI?
That's the frontier, isn't it? Moving beyond damage control and toward true tissue repair. A critical thought for you, the learner, to explore further in advanced neuroscience texts.
A fascinating and critical challenge for the next generation of surgeons. Thank you for diving deep with us. We hope this has equipped you not just with facts, but with true, actionable understanding. We'll see you next time.